Good morning or good afternoon, everyone, whatever time it might be where you are. It's 10 o'clock in the morning in Senegal. So I am going to share my screen for my slides. And we are going to go directly into my topic for today, which is basic life support, focusing on cardiopulmonary resuscitation, and then highlighting some of the American Heart Association highlights. So thank you very much. All right, so basic life support, cardiopulmonary resuscitation, and because of this current situation, the pandemic, the American Heart Association has given some guidelines to help us navigate this period. So we will say something about some of those recommendations and highlights in this lecture. My name is Dr. Adamson. I am an anesthesiologist principally, and basic life support, pediatric advanced life support is my passion. So I'm going to share with you a subject that's very dear to my heart. I'm not sure how to move this.
Dr. Adamson, could you just go to the down to your left? You will see some icons there. You can navigate from there.
All right, thank you. Okay, here's the outline. We are going to talk about the global and growing burden of cardiac diseases in general, and mortality and incidence rates related to cardiac diseases and cardiac arrests around the world. I will share some general concepts and the science that's driving basic life support and cardiopulmonary resuscitation techniques. And then we will go into CPR itself, describing the chain of survival and justifying it. And then we will talk about, we'll summarize the components as recommended by the American Heart Association. And then we will look at the COVID considerations. Cardiovascular diseases, especially cardiovascular deaths, is actually a public health problem nowadays. As healthcare is improving around the world, we are discovering more and more that cardiovascular problems are beginning to come to the forefront of our fight in healthcare. So we do have frontiers to overcome as far as cardiovascular resuscitation and life support is concerned. Over 135 million cardiovascular deaths a year is the prevalence rate that's given, with coronary heart disease increasing according to research. Globally, the incidence rate of out-of-hospital cardiac arrest ranges from 20 to 140 per 100,000 people, and survival ranges from 2 to 11%. We will put these figures in context as we go on. Out-of-hospital survival rates range from 3 to 16%, according to some research that I have highlighted here. I found some interesting data from the National Health Services from the UK that gives survival to discharge rates in their ambulance system between 2 to 12%. Now that's an industrialized country where response time is short and equipment availability and training is supposed to be superior to some of our settings. But we see that the survival rates are still very low. The median hospital survival rates in the studies, especially from the regional variations in out-of-hospital cardiac arrest incidence and outcome study in 2008 from the JAMA network, says that the median hospital survival rate from adult cardiac arrest is 18%, with interquartile range between 12 and 22. And then we have 36% for pediatrics. That's for hospital survival rates. In hospital settings, I thought it was going to be interesting to bring out these realities. Survival rate is a little higher and is pegged at 20%. Now that is if the arrest occurs between 7 and 11 p.m. And then it drops down to 15% if the arrest occurs between 11 p.m. and 7 p.m. So there's a significant variability here in regard to location. And then furthermore, the survival rate is at night is at 9% in an unmonitored patients. But if you look at patients who are monitored and who are being surveyed or around the clock, the percentage is higher at 37%. Very interesting. So these figures should bring out certain realities that we can draw some conclusions from these figures, as you might predict. But I will not go ahead of myself here. Let's just lay down a few definitions. Cardiac arrest is an electrical problem, and we should not confuse it with heart attack, which is a circulation problem. Cardiac arrest is triggered by an electrical malfunction in the heart that causes an irregular heartbeat, what we normally call an arrhythmia. And so the pumping action is disrupted. The vital function of the heart is disturbed. So the heart cannot pump blood to the brain, lungs, and other organs because of electrical malfunction. Whereas a heart attack itself, like I said, is a circulation problem. So a blocked artery will prevent oxygen-rich blood from reaching a section of the heart. So if a blocked artery is not reopened quickly, the part of the heart normally nourished by that artery begins to die. Between cardiac arrest and heart attack, there is a link. We can say that most heart attacks do not lead to cardiac arrest. Usually people survive. But when cardiac arrest occurs, heart attack is usually a common cause. There's obviously other conditions of heart rhythm disturbances that lead to cardiac arrest. This is a foundational truth because what we're going to discuss later, the science is based on this consideration that cardiac arrest is basically an electrical problem. So most cardiac arrests in adults are sudden, resulting from primary cardiac cause. Circulation produced by chest compressions is therefore paramount. So we need to innovate and keep the pump function of the heart while to buy us some time is the basic concept here. In contrast, in children, however, we all are aware that cardiac arrest in children is most often asphyxia. it usually requires both chest compressions and oxygen supply in terms of ventilations for optimal results. Furthermore, if we consider cardiopulmonary resuscitation as a definition, it is therefore a series of life-saving actions that improve the chance of survival following cardiac arrest. Although the optimal approach for CPR may vary, depending on the rescuer, their experience, the victim, the causes, the fundamental challenge here is to achieve pump function, otherwise here later on referred to as cardiopulmonary resuscitation. So conventional CPR, consisting of manual chest compressions interspersed with rescue breaths, is very, very key to survival in cardiac arrest victims, wherever they may be, in hospital or out of hospital. We can buy time with compressions, with chest compressions, with rescue breaths. I would like to highlight a number of scientific inventions and some of the alternatives techniques that are out there that are giving an alternative to manual cardiopulmonary resuscitation or chest compressions, as we call them. Just to throw your way some of the things that are happening in the scientific world and in the resuscitation world. I would like to mention 4 elements specifically. Mechanical chest compression devices that are out there. And then we have impedance threshold devices, ITDs. We have ACD, or active compression, decompression CPR gadgets. And I think one of the growing and the most researched actually right now is extracorporeal membrane oxygenation techniques. So these are out there, and I put out a few pictures here. This is the Lucas chest compression device. Lucas is Learned University Cardiac Arrest System, which combines. It's an automated mechanical compression device whose job is to provide high quality compressions mechanically or automatically. So it's battery powered, and it has some advantages, especially where manual compressions or conventional compressions are difficult, like in a moving ambulance, or when compressions are prolonged, like in hypothermic patients, CPR during certain procedures like coronary angiography, or preparing for ECMO. And it provides, it's mechanical, it's automated, so it eliminates the physical barrier of tiredness, and when people are tired, they don't compress as effectively. So it's an interesting thing, but we need to mention here from the start that evidence does not really demonstrate a benefit in the use of these things. Manual chest compressions remain the standard care for the treatment of cardiac arrest, and like I said, it depends on availability and settings, and other conditions that you might find yourself in. But it's worth noting. It's out there. Another device is the impedance threshold device. This actually is a device that stops extra air from going in during during chest compressions or resuscitation efforts. We know that the human body continually circulates blood using positive and negative pressures inside the chest. So this regulation acts like, like a bellows. When you inhale, a negative pressure is created in the chest. And this negative pressure forces blood into the heart and air into the lungs. And then it also lowers, because of the negative pressure is transferred through the vessels into the brain, it lowers the intracranial pressure. And then the opposite happens when we exhale. Opposite pressure is created in the chest, and this pressure forces air out of the lungs, diminishes blood return to the heart, and slightly raises intracranial pressure. When the pressure is low in the chest, blood flow enters. So this device stops more air rushing into the lungs during cardiopulmonary resuscitation, maintaining the negative pressure, and so improving blood flow back to the heart. And we all know that what is in the heart is what is pumped out. So when we pump, what is in the heart goes out. If what is in the heart is not enough, not much will go out. So that's what the impedance threshold device does. So it can be hooked onto the mask, the breathing mask, or any breathing device that we use during resuscitation. This is the active compression decompression device. It works on the same principle. In order for blood to circulate, we need to with chest recoil. When chest recoil happens or decompression, blood comes back into the heart. And we know that that recoil is passive. It's a passive mechanism. This device tries to make that active. So create an active recoil phase during CPR. So re-expanding the chest and allowing intrathoracic pressure to fall. And so it does the same thing. Recoil may be compromised due to various causes like poor chest compliance, or excessive fat, or excessive fast or rescuer leaning on the chest. So those things can disturb the negative positive pressures, which are so crucial to preload and output. So ACD CPR is beginning to becoming very, very popular because it actually has been shown to improve neurologic outcomes after CPR when people have recovered. So it has a pump. It sucks like a plunger that you use in the toilet, and it lifts up the chest. Some of them can lift the chest up to about with a force of 10 kilograms. So it improves negative pressure and improves heart filling, and thereby improves blood circulation because of preload increase. And then based on this, like I said, neurological outcome has been seen to improve, especially when ACD and ITD are combined together. And I think they should be considered as adjuncts in BLS and advanced life support as an essential element in the future. So to finish with the gadgets, ECMO, I think, is what is being used in advanced centers. This is extracorporeal membrane oxygenation, which is connecting the circulation system to an external system of circulation. And it's very promising. And some studies have shown an increase of up to 1/3 cardiac arrest victims in terms of survival post-cardiac arrest. This is what the 2015 American Heart Association guidelines have said regarding these gadgets. So routine use of ITDs as a conventional adjunct to CPR is really not recommended. Right now, according to the 2015 recommendations, the AHA guidelines and the European Resuscitation Council. This is the routine use. We need to underline the word routine. So it should not replace conventional chest compressions. The second thing is randomized controlled trial suggests that ITD plus ACD CPR, when they're associated, they have an improved neurological outcome, especially for out-of-hospital cardiac arrest patients. So maybe ambulances will circulate more with these devices. The routine use of mechanical chest compression devices is not recommended. Again, we need to underline the word routine use. But special settings, as I have said earlier on, where this technology may be useful can be identified. The use of eCPR may be considered for selected patients in settings where reversible cause of cardiac arrest is suspected, especially in children where cardiac arrest is usually asphyxia. So there is sufficient evidence to recommend the routine use of eCPR for patients with cardiac arrest. In settings where it can be rapidly implemented, eCPR may be considered for select cardiac arrest patients for whom suspected etiology of cardiac arrest is potentially reversible during a limited period of time. So that's all I had to say on what's out there in terms of gadgets and what AHA and ECC advise us. So CPR, or cardiopulmonary resuscitation, is an emergency life-saving procedure performed when the heart stops beating, which is usually, as we have seen, an electrical problem. So immediate CPR can double or triple chances of survival for cardiac arrest victims. Patient survival is linked to the quality, and I underline the word quality here, quality CPR. Obviously, quality comes with a few things attached to it, like training, like equipment, and awareness, and things like that. So high quality CPR is the foundation of life-saving resuscitation for cardiac arrest victims. All health workers should be expected to perform CPR effectively and competently. Everyone should have the reflex, even to give hands-only compressions. Hands-only compressions, that is CPR without rescue breaths or breathing. And this is justified because initially during cardiac arrest, oxygen levels in the blood remains adequate for several minutes. When the heart stops beating, it doesn't mean the pool of blood in the system has suddenly become deoxygenated. The blood that's circulating might have, for several minutes, some oxygen still in it. So cardiac arrest victims may exhibit gasping or agonal gasps, and gas exchange will help to eliminate carbon dioxide. So if the airway is open, passive chest recoil during relaxation phase of chest compressions can also provide some air exchange. We will talk about that later when we talk about the change from ABC to CAB. But this was just to highlight that even if you are not able to ventilate a patient, hands-only CPR is highly recommended by most of the resuscitation societies. So this requires an integrated set of coordinated actions presented by the AHA as a chain, actually known as a chain of survival. So we have links as just like in a chain, and on top we have the in-hospital cardiac arrest and out of hospital cardiac arrest chains of survival. You can see that the difference between in-hospital and out of hospital is that out of hospital, you start with calling for help, alerting and calling for help. People need to be trained to recognize quickly cardiac arrest and call for help, and then start chest compressions. Whereas in hospital, the first two links are linked to prevention, surveillance, and anticipation, and then calling for help and starting with chest compressions. We will go through these links one by one, but let me show you the pediatric version of this link. You can see that it starts with prevention, because as we have said, in children, most cardiac arrest outside congenital cardiac abnormalities and a few rare electrical problems, usually cardiac arrests are asphyxia. So prevent, survey, and then chest compressions, and then call for help. Who do we call a child? The AHA definition in resuscitation, in our resuscitation sciences, a child is anyone 1 year of age up to puberty, and puberty here is considered as when someone has hair on the chest or in the underarm in males, and breast development in females. And then adults are adolescents after the onset of puberty. And then we have another category where we have put a small child or infants. These are those who are under 1 year, at the exclusion of newborn babies who have a different needs in terms of resuscitation, and they're not going to be considered in this lecture today. So let's come back to the chain of survival. I will highlight here, starting with the in-hospital chain of survival. So surveillance. For adult victims.
Hello, doctor. Hello. You've been speaking for about half an hour now. Nearly half an hour you've been speaking. So you have you've been speaking for about half an hour now.
Yeah, I have 15 minutes.
Yes.
Yeah.
So you can go on. Yes. Okay, go ahead.
I should cover it in about that time.
Yes.
So yeah, adult victims, respiratory or circulatory conditions get worse, so we need to survey them. As I said, many arrests can be predicted. And then activation of recognition of cardiac arrest. I need to highlight here that unresponsiveness is an important thing in cardiac arrest, which is, I think, for health workers, sometimes something that is overlooked. The patient who is unresponsive, not breathing, no normal breathing, or only gasping, and then pulse comes as the fourth, no pulse comes as the fourth element. So if this criteria, any of these criteria are met, you activate the emergency response system and ask for help. And then you start chest compressions, and we say chest compressions of high quality. And AHA recommends 30:2 ratio with 100 to 120 per minute with a good depth. Allow chest recurve, so don't lean on the patient. Minimize interruptions and give breaths that make the chest rise and avoid excessive ventilation. We want here to aim at a chest compression fraction of 60%. Chest compression is the total number of compression that we give during a period of resuscitation. Like I said, rescuers should initiate chest compressions first. And then you can give rescue breaths. So we minimize emphasis on breathing because chest compressions do help in filling the lungs with oxygen. And the important thing here really is to circulate, to make the pump function. Chest compressions, when they are interrupted, they take a long time. You take a long time to develop, to come back to your initial perfusion status. So we avoid interruptions and privilege chest compressions. The next element in the link is defibrillation. Rapid defibrillation is a part of high quality, considered an element of high quality CPR, and does double or triple even the chances of survival, because cardiac arrest, as we have said, is an electrical problem, usually the ventricular fibrillation and other electrical problems. So AEDs are, an AED is an automated external defibrillator, has been incorporated in CPR. These are automated. They are programmed to recognize rhythms that are shockable, and they are very easy to use. There's actually even an ambitious program around the world to dot every area of public gathering with AEDs. Their use is easy. Usually you follow the instructions, and they will defibrillate and shock, and they will not deliver synchronized shock, but they will recognize very fast heart rates like ventricular tachycardias. So they should only be operated when a patient is unresponsive, because patients can have ventricular tachycardia and still have a pulse and still be responsive. We need to remember that victims in water, it's not recommended, and those who are younger than 8 years, because the electrical charge in these elements is prefixed. So as the dosage is 4 kilojoules, 2 to 4 kilojoules per kilo, patients with less than 25 kilos usually will get more than they need, and it might be not helpful. Be careful also with people with pacemakers. And usually they are easy to use. You turn it on, put the pads on, and it runs you through the elements. And then the last link, almost the last link here, is once spontaneous circulation is achieved, the patient is better provided for in a multidisciplinary team approach, where survival is optimal with a multidisciplinary teams. So we need to develop a culture of dedicated resuscitation teams, which still is a challenge in our setting. So I think the rest is just the algorithms, and maybe what the important thing in the COVID era is the inclusion of protection, PPEs, and protecting yourself from, especially in ventilation. So these will probably be shared with you in the notes. So protect yourself, call for help, reduce risk, and ensure a good ventilation goal. And then this slide is just for the rest of the recommendation. There's an e-learning interim guideline on resuscitation, and there's a lot of help on the AHA resources. And my recommendations at the end of this lecture is that we should train people in BLS, in PLS and ACLS. And people should get AEDs, and we should go towards resuscitation teams in our hospitals and in our centers, and we should provide feedback and improve this science, because sometimes we have two good hearts that die. Thank you.
Doctor, thank you so much. This a wonderful lecture. Hello, participants. I'm sure you all heard Dr. Adamson very well. And we'll go to the chat room and look at the questions. Dr. Adamson was trying to talk to us about resuscitation, the gadgets that are available, and how to go about it. There was a question. How do I go to the chat room, please? Hello? NK? How do I get?
Just go to the bottom of your screen.
Yes.
You'll see more, extreme right, and
Yes.
click on it. Yes.
Reactions? No. I didn't get that. I see, I didn't get you, please. But I was having it, the chat. Okay, all right, good. Okay. So thank you once again, Dr. Adamson, thank you. Yes. The question I have here, okay, I can't read now. Somebody talking about if there's an incident in the mall, the person who has stated, do you have to send the person to the hospital again the same day, or you can discharge the person from the mall? But can you hear me, Dr. Adamson?
Yes, yes, yes. Can I respond
Yes.
to that question?
Yes.
Thank you very much, and it's a very good question. And talking about malls here is important because we know that there's an ambitious program to put these AEDs in public places, in schools, in malls, in trains, in aeroplanes, in taxis. First of all, because of the science that cardiac arrest in adults especially is an electrical problem. But if you look at the link of survival, the logical thing after a successful return of spontaneous circulation, if a patient has been defibrillated and resuscitated, the logical thing is not to go home, but to go to a center for integrated multiple disciplinary team investigation and treatment. So that's one element. The link advises us to after return of ROSC or LOSC, return of spontaneous circulation, that you should go to treatment with an interdisciplinary team. Another thing that's worth mentioning here is that cardiac arrests have a tendency of reoccurring because there's usually an underlying cause. So it's better that someone comes back to life. They need to be investigated. They need to, we need to find out why it happened in the first place, and then move back to the first link of the chain, which is prevention and surveillance.
In other words, the resuscitation in the place of occurrence is the beginning of the treatment. It doesn't end there. You have to continue the treatment, investigate in the hospital. I think I understood it that way. Is that right? Adamson?
Yes, that's correct. So
yes.
CPR is just the beginning. Is to buy us time.
Yes.
buy us time so that we can.
There's another question here.
Yeah.
The participant wants to know what could cause cardiac arrest. You know, you talk about two types of things, like cardiac arrest and the other one, and you try to differentiate between the two. Here, he wants to know what can cause cardiac arrest. Yes.
So let's divide that into, usually in out of hospital settings, cardiac arrest would usually happen because of electrical problems of the heart, ventricular fibrillations, and other electrical problems of the heart. So these would be probably patients who are already cardiac patients on treatment who get worse, or they could be patients who have undetected or undiagnosed cardiac events. And in our days today, we hear a lot of young people that just drop dead. And so this can happen because of intrinsic cardiac problems. Out of hospital, it can also be related to accidents, poisonings, for patients who take opioids for pain, chronic pain, can overdose themselves and have that as a cause, hypoxia leading to a slow heart rate, leading to a cardiac arrest. Out of hospital, also we can think about accidents, road traffic accidents, home accidents, drownings, and other causes of cardiac arrest. Whereas in hospital usually patients, it can be a complication of an existing problem, a complication of the treatment, leading to any causes of hypoxia, ion disturbances, electrical disturbances, not to rule out also overdoses and other disease processes, whether they be cardiac or extracardiac. But what we need to remember is that there's a difference between cardiac arrest and heart attack. Heart attack is really very symptomatic, and it comes on gradually, and it can lead to cardiac arrest. But cardiac arrest is a sudden stop, derangement of electrical activity of the heart, resulting in inadequate or actually no pumping at all. And that's the basis, scientific basis for CPR. Now we can go into very specific details of actual causes, but in this lecture, as a big, broad brush, we would say we could classify causes of cardiac arrest in terms of those, with a special particular emphasis on children whose hearts arrest because usually of hypoxia. If they don't breathe well, they're not oxygenated well, they become bradycardic, and then the heart stops to pump. So because there's very few electrical problems with children outside congenital cardiac abnormalities. I think I would broadly categorize cardiac arrest in those areas. Now, sometimes we make a cardiac arrest a diagnosis. It actually is not. Cardiac arrest is actually the definition of death itself. So you need to find the cause. And the good thing here is that it can be reversible, and it is reversible. I hope I answered that question. It's broad, but over to you, Prof.
This is Philip. I will just step in a while for Pius while we continue the questions. There was one a little bit related to this, which maybe you just respond. I'll take about 3 questions. The other one is specifically to cleft surgeries. What is the commonest cause of cardiac arrest in cleft surgeries? That's one question. The next one is, in these times of COVID, By the time one puts on PPE, isn't time lost for resuscitation? And the last one is, when you were making your presentation, you said the guideline does not advocate the routine use of ITD with conventional CPR. Any reason for this?
Thank you very much and welcome. Thank you for stepping in. So, cleft surgery. We know that the majority of our cleft patients are children because this is a congenital abnormality, and so most of the bulk of our patients will be pediatric patients. And there will also be patients who will either might be, they have other congenital abnormalities associated with their cleft. And some of these malformations could be cardiac or other congenital abnormalities that will predispose them to cardiac arrest. So that should be borne in mind. But that said, I think hypoxia and drug-induced and not the follow-up or the surveillance, which is not very strict, can lead to a lot of these accidents. If a child becomes hypoxic, if a child becomes hypoglycemic, if a child becomes hypovolemic, if a child becomes hypothermic, those elements are very, very crucial, especially intra-op. If the patient is anemic, if a patient is, has co-infections, they predispose them to events that will lead to tachycardias and rhythm problems and then cardiac arrests. And then anesthetic management is also a big risk. We need people who are able to anticipate and put to sleep safely and children and monitor them correctly and react in time, especially respiratory and airway problems in the post-op period. In the immediate post-op period, especially patients with cleft palate, we know that this is an operation that's intrabuccal, and so secretions can go the wrong way, and they can inhale. Usually, we put throat packs to protect the airway, and if this throat pack is not taken out or it goes down the wrong way, the child is not able to breathe, becomes hypoxic, and they'll die. So I would say in our setting in cleft surgery, we should screen children correctly and adhere ourselves to the recommendations. Especially Smile Train has very good recommendations to avoid this. And if we adhere to those, we will run into less problems as far as cardiac arrest, intra-op or immediate post-op is concerned. You know, if we anesthetize a malnourished child, we are exposing ourselves to poor metabolism of common pain medication that can lead to respiratory arrest or depression, hypoxia, and then cardiac arrest. So if we adhere to those recommendations, we probably will we'll reduce cleft surgery-related cardiac arrests. Proper screening, good anesthetic care, intra-op and post-op. I think that's very, very important. And we know that syndromic children should be reserved for centers that are well prepared to handle this type of eventualities. Now I can give a whole lecture on that, but I think in general, in cleft surgery, those are the things to look out for. So with the interim recommendations for COVID, Is there time lost for someone to put on to put on the equipment? Yes, of course. And I think that boils down to priorities. My personal take on this one is that we need to protect ourselves. The least thing we can do is maybe put high oxygen pressure with a breathing device, with a filter to protect ourselves as we do CPR and as we wait for a team which is well prepared to take over. But it's the same as should we do mouth to mouth in this area in this time, or should we just do hands-on CPR with someone covering the mouth to avoid aerosol display as we wait for a team? And ideally, in resuscitating areas and in hospitals, these equipment should be available. And I know that maybe we have problems with those, but that's the ideal that I'm describing here. But you are right, time can be lost in wanting to protect ourselves, but it is the chain of survival. You need to assure that the environment is safe before proceeding, and that includes protecting yourself. So ITDs, the 2015 recommendations from ECC and AHA is that they should be, they should not become the routine use. I think it's because of a few reasons. They are not widespread. They are not widespread yet, and they are still on the expensive side. So we cannot make them a requirement and substitute them for conventional CPR. And there's still a lot of studies that are going on. I'm not sure they're FDA approved as at now. I know that ACD, there's an ACD that has been FDA approved. But routine use is really not recommended because of availability and training and costs. But otherwise, it is recommended when it is available and when it can be used. So I don't know if I have covered the questions.
Yes,
if I need to
Dr. Adamson, thank you very much. I will say Pius is back, but we just have 2 more questions and we have 3 minutes left. So I'll ask the question,
Yes.
then Pius will wrap up. So the question, 2 questions left. You said, what would be your advice for a patient who suffers a cardiac arrest at the induction of anesthesia, but is successfully resuscitated? So on the table, patient is in the stage of induction, has a cardiac arrest, but successfully resuscitated. What would be your advice? I believe maybe to proceed with the case or not, I just assume. The last question is, you mentioned a particular program that is looking at making AEDs available for all public gatherings. Can you provide the link for such? I know you kind of discouraged that, but the person is still interested in the link. Before you respond, I wish to say there are many comments saying thank you very much for the lecture, a great lecture, especially that people now know the difference between a cardiac arrest and a heart attack. So when you answer these 2 questions, then Pius can continue.
Thank you. Thank you so much, Doc. My personal advice on cardiac arrest on the table, if it's happened before surgical intervention has started, our policy is if the surgery is not life-saving, if it can be postponed, we need to postpone the surgery and make sure that the resuscitation, the ROSC, has good neurological outcome. I would take the patient, whether they are fully awake or not, I would take the patient to a high dependence unit or an ICU for monitoring and for further investigations, and apply the last link of the chain and multidisciplinary team, highly disciplined team to look at this patient and try to figure out, was it only anesthesia or there are other underlying causes. So it depends on the surgery really, if it's not life-saving, if it can be postponed, if the surgeon had not yet started at induction, as you have said, I would wake the patient up and assure myself that the resuscitation was really effective in terms of neurological evaluation. However, things might change if you were midway through the surgery. If it's an emergency surgery that the patient depends on it for survival, then I think collegial discussions with the surgeons would probably be what should be done, and proceed with the surgery and then move the patient to ICU for monitoring and evaluation of neurological benefits of resuscitation. The other question was on AEDs. I think the ambitious...
The link to where providing AEDs in public places, is there a link to get that information?
Yes, there's a link. There's some studies. There's some studies that have been done, and if you write in my inbox, I can give you the links because I didn't include them in my presentations.
Dr. Adamson, this is a NK from Smile Train. You can send the link to me, so when we are sharing the materials, we would send it alongside.
Okay, so ITD link, especially in COVID use, I will. AEDs, basically the prices on them has come down, and the program, there's a lot of research that's going on and a lot of recommendations that's going on in industries, in places where public places. So I would, if you are in a hotel, for example, and there's a sign for a fire extinguisher, but no sign for AED, you should call them to attention for that. So I think it's a good initiative in swimming pools, in restaurants, hotels. I think it's a very good initiative because of the science behind it, that fibrillations and electrical problems cause the majority of cardiac arrest. And if defibrillation, which is the treatment of choice, is given quickly enough, then we can have better outcomes for CPR. I'm not sure I had the question correctly, but
thank you, Dr. Adamson. I think there's another question here. Thank you so much, SG. May I continue? The best window period to initiate CPR. I don't know if you addressed that question already. The best window period to initiate CPR, have you?
No, I haven't addressed it. I've just seen it. Okay. The best window period to initiate CPR, again, is if you look at the chain, the chain of survival, as soon as cardiac arrest is suspected or diagnosed. So in a patient who is not responsive, in a patient who is not breathing normally or has gasps or agonal breathing, in a patient who has no pulse, CPR needs to be started immediately. That's for in hospital. For out of hospital, we need to teach people that if someone collapses in front of you and you check them for responsiveness and they are not responding, CPR should start immediately. So those are some of the best periods. CPR should be initiated as soon as cardiac arrest is suspected or diagnosed. Even a suspect of cardiac arrest, when you compress the thorax of someone who is not in cardiac arrest, it can actually help you to know that they are not in cardiac arrest, and then you can stop. So you lose nothing. But if you don't start immediately when you suspect cardiac arrest, you might end up losing the patient, if at all it actually was a cardiac arrest. So we look forward, it says we look forward to a lecture on cleft patients and cardiac arrest. I would like to be able to do that because it's a topic on itself. And there's no reason why we should have that if the recommendations are followed to the letter. And there will be very isolated cases where this happens, and so we will not have incidences or events of that sort with our cleft patients. Prof?
Pius, over to you. Dr. Adamson, thank you very much. A very lucid and interesting lecture, and indeed we've gained a lot. We also want to thank Smile Train at the West African College of Surgeons for continuing this and maintaining this series. It will continue next week, Monday, same time, 1000 hours GMT.